So these are my slides. Okay. Well, good morning. And first of all, let me congratulate Augie on 20 years for this symposium. I don't think there's another one quite like it in the country. And I'm so grateful to her for everything she has done, for all the influence, the positive influence she's given us, the encouragement she's given us, because it has been a very difficult road. And I appreciate the honor of being here to talk to you today. Well, Dr. Donahue sort of kind of told my story a little bit. I've spent my entire, I'm trying to figure out how to advance the slides here. Let me try that. Okay. I've been trying my entire career to reduce the burden of pancreatic cancer through both early detection and treatment. But I focused mostly on treatment because, after all, I am a medical oncologist. That's what we do. And I did a lot of things. I spent 4 decades doing this. I helped develop treatments. I helped disseminate treatments. I led the NCCN Pancreas Cancer Guidelines Committee for 28 years. And you know, about 3 years ago, I started to think about what else could I do. And let me explain why I was thinking about that. You know, you've all seen this. You've all seen the fact that as we get better and better with treating other malignancies, the likelihood of dying from pancreatic cancer keeps increasing. And it could overtake lung cancer at some point. And this is because the incidence is increasing. Our treatments have been somewhat limited, but I totally agree with Dr. Donahue that I think we're at an inflection point between the development of the RAS inhibitors and what they're going to be able to do. They're not going to cure or be totally transformative, but they're going to open the door to other potentially transformative therapies. And I think the vaccine area is very, very exciting. It is holding play in other cancers, and we're seeing early signs of promise in this disease. So I do think we're at an inflection point. But only 20% of patients, that's the green part of this pie, 20% of patients present to us with resectable disease. And we know that that's a key, right? The less disease you have, the more chance we have of helping you overcome it. And I began to think about that and realizing that we don't have really screening only for patients with hereditary predisposition. And we screen with EUS and alternate it with a form of MRI that details the ducts in the pancreas. But we don't have a strategy for the average person at risk, only for those with hereditary predisposition. So in 2023, I sat down in my little desk at UCSF and began to think about all the things that I could do. And how could I focus on early detection in pancreatic cancer? So I thought about all the things that are emerging. Some are already available, but other things are emerging. And I realized that that was too narrow a vision, that there are a lot of deadly cancers that we don't have an early detection strategy for. In fact, the U.S. Preventive Services Task Force only recommends screening for 4 different types of cancers, and the 5th being prostate cancer, and they recommend not screening but talking it over. So we've got a lot of deadly cancers that we don't have a strategy for. So I thought, well, maybe that's what I should be aiming for, is a bigger vision. So I went to the leadership of UCSF, and I said, here's the deal. I want to take a sabbatical, and I think we should have a center for early detection and interception, And I'd like to work on my sabbatical, during my sabbatical, work on it and create this center. And it'll take care of all these cancers, hopefully, that we don't have a strategy for right now. So you can read the vision and mission, but it's pretty much what I showed in all my little thought bubbles, like how do we pull all of this together? So I did it. I created an organizational governance structure. I'm the director of this initiative. I have disease site advisors because, believe me, I know I don't know everything. I have a steering committee. I have teams that assess technology and both in imaging and blood-based assays, as Dr. Donahue was talking about before. We have a clinical unit. We have clinical research. And we're working on it. We don't quite have it yet, but we need education and outreach so that we can inform the public about, what is standard of care and what shows promise and what are the pitfalls, positive and negative, of trying out some of these new blood-based assays, for example. So this kind of gives you a sense of my wheel, my circle of support. And we set up something that is very new for cancer centers. It's a cancer diagnostic service where if someone has a signal of some sort, they can come directly to our cancer diagnostic service and we can begin to work it up. And that's new for cancer centers. Cancer centers have not traditionally done that in the past. These are all the folks that are involved hands-on in our cancer diagnostic service. And what we've really done is open a door. So before the door was closed, if you didn't have a diagnosis of cancer, you couldn't get into the cancer center. You had to have a diagnosis. Now we have the door open where if there's a signal, we can take advantage of it. So what's happening, and I think you're all well aware of this, if anybody has tried to get a primary care doctor, a new primary care doctor, good luck. And so we have people showing up in the emergency room with one thing or another, and they find something, and they say, oh, well, you should go back to your primary care doctor and have this other thing worked up. And they say, well, I don't have a primary care doctor. Okay, so they send them to us. And the other thing that we're starting to see is that primary care doctors who are really, really busy, I don't know how they do what they do, but they're managing your hypertension, your heart disease, your diabetes, all these other chronic illnesses, and they don't really have a lot of capacity to take on something else. So if there's a signal that something isn't right, they love to send the patient to our cancer diagnostic service. So all that we need is a referral from a physician that where the patient has something that is suspicious for an underlying malignancy. And then we can see them and work them up. And because we're in the cancer center, we know how to quickly get the right test done. That is one of the issues in the primary care field because they don't always know who to refer to or what tests are the right tests to order, how to do things efficiently. So we've created pathways so that we can work up things efficiently, and then because we are a big cancer center, we can hand that patient off to a specialized team right away. So there's no delay. Most of our cases are being resolved within 2 to 3 weeks. So what are some of the things that are sort of emerging? And Dr. Donahue mentioned a couple of these, but is there a high throughput strategy to detect cancer or even multiple cancers? You know, right now, when we screen for cancer, for breast cancer, we screen with mammograms. For colon cancer, we screen with standard of care is screening with colonoscopy. For lung cancer, it's a low contrast CT scan. But, it'd be so nice to be able to just have a little blood sample and be able to look for multiple cancers. And this really grew out of the field of liquid biopsies. So we know that cancer cells in a patient with cancer, they break down. And there's lots of material that circulates in the blood. Even the tumor cells can circulate in the blood. We've known this for decades. But only now have we had some of the tools that allow us to amplify even minute quantities of material in the blood and then be able to analyze it. And so that's where the field started, but it evolved out of our ability to do liquid biopsies. You can even get, I don't know if I have a pointer. I'm not very good at using the pointer on the podium, but you can see that in the blood there, the little thing called exosomes, that comes from viable tumor cells. Viable tumor cells will, like a little bubble, a bleb will develop on the tumor cell, and that whole package gets released into the bloodstream. And that is packed full of really useful information. So this basically says what I just said, but also adds the fact that there are other things besides what the cell has in it that might be useful. When you have a cancer developing in your body, your immune system says, something is different here. And so there are immune sensors that can be detected within the bloodstream. Or the cancers have very different metabolism than our normal tissue. And so there are products of their differing metabolism that can be released into the bloodstream. So there are lots of other analytes besides what can come from the tumor cell. And when we're looking at these new early detection tests, what we're looking for most importantly is stage shift. Are we detecting cancers earlier? Dr. Donahue talked about a big trial that didn't actually, it was done at the National Health Service with the Gallery test that was developed by Crail, but they lumped stage 3 and 4 cancers together. So he was absolutely right that they didn't see a difference in the 3 and 4, but they saw a 20% difference in the stage 4. We cure a lot of stage 3s. We don't cure too many stage 4s. So if you shift to an earlier stage, you're going to have easier treatment. You're going to have less morbidity, hopefully less mortality, and better quality of life. On the other side of this scale, though, are some serious things to consider. Are we going to cause a lot of anxiety by possibly having a false positive test? This happens. Are we going to overdiagnose? What we want to find is cancers that have to be treated, that need to be treated, that should be treated. But there are many cancers that you don't really have to treat. Prostate cancer is a very good example where a lot of prostate cancer that's diagnosed does not require treatment. It can be observed. So you don't want to overdiagnose, overtreat. You don't want people to say, oh, if I'm going to get a blood test, then I don't have to have all those other standard of care tests. No. We want you to have those standard of care tests that are proven to reduce mortality. And then, of course, you have the economic burden of, again, the false positives and additional workup that wouldn't have been done at all. And maybe there could be some adverse event that happens in working up these false positives. So it is a very delicate balancing act. So right now there are 4 tests that I think are out there advertising to the public about their ability to detect pancreas cancer. One of them is PancreaSure, which was developed by Immunovia, and the other is Avantec, which is developed by ClearNote. These are not ready for prime time, although they are being advertised to the public. Multi-cancer detection, the 2 most prominent ones are Grail's Gallery test and Exact Sciences Cancer Guard. The Grail Gallery test does provide a tissue of origin, so you have kind of an idea when you have a positive signal about where to look, and that's very important. The Exact Sciences test does not have a tissue of origin. And of course, insurance does not cover these tests because there's insufficient data to support their use in standard of care. So that's why we are so determined to understand whether these tests have value through clinical trials. Another thing that's happening, and I'm sure you've seen the advertisements, is a lot of direct-to-consumer marketing about a whole-body MR. Come in and get the family plan, for so much money, you'll get 3 MRs 3 years in a row, and so on. It's not clear yet whether those have any basis. They are not harmful except to your wallet, but there's no radiation involved. So there's no downside that I see of doing it, but I can tell you when we get a positive signal off a Prenuvo scan, the first thing that my radiologists do is say, well, let's get a really good MR scan, because the quality is not what you would see at UCLA or at UCSF. So back to pancreas, the high-risk groups that justify screening are these selected hereditary cancer syndromes. And we know that, Dr. Donahue spoke to this, that a significant percentage, about 8% of patients diagnosed with pancreatic cancer got that cancer because they were born with a gene that promoted it. And now that we understand that and we're testing for it, then we have cascade testing within the families so that we can understand who actually is at risk for pancreatic cancer. And I think, so if you've been here before, you've probably heard Dr. Diane Simeone talk about the PRECEDE Pancreas Cancer Early Detection Consortium. We're very much a part of that, and I believe you are too, UCLA is too. And this is really, really important because it's going to be the largest study ever establishing cohorts of patients with many different types of mutations that can predispose to pancreatic cancer. And there's also the opportunity, and it's evolving yet, but for studying cystic neoplasms that can transform into cancers. So this is a big collaborative effort. It's led, as I said, by Dr. Diane Simeone at UCSD. So I'm proud she's now at one of the UC campuses. And, it's really trying to unravel all of the questions, all of the issues that we have in these high-risk families, because there's a lot of them that are truly high risk and absolutely should be screened, and there are others that might be, but we're not sure, and maybe it's related to a certain point mutation, but we don't have enough patients yet. So we're gathering data on, right now, 10,000 patients. We just expanded that. We're going to go to 20,000. I won't read all of this, but basically it reiterates all of the goals of the consortium and what we're trying to do. And the potential as a platform for being able eventually to actually do screening trials and do other types of testing. There are lots of centers in the United States. There are centers all over the world, including all of Iceland. And both Immunovia and ClearNote, with their assays, are collaborating with PRECEDE to assess the usefulness of their assays for diagnosing pancreatic cancer. So what we're doing with these cohorts is we're collecting blood on an annual basis and then watching to see they're getting screening if they qualify for screening. Some of these patients will get pancreatic cancer. We will have already banked their specimen from prior years. And then these tests that are in development can be used to understand whether that test would have picked up this pancreatic cancer 1, 2, or 3 years earlier than we did clinically. So what about the rest of us who are not at high hereditary risk? What's going on there? We know that if you take all the risk factors, alcohol, these are minor, diabetes, alcohol, smoking, you can add them all together and you still do not reach a threshold that's required for cost-effective testing. So we have to think differently about this. How are we thinking about it? Well, If you haven't been thinking about AI and what it's doing in your life, something's wrong with you. But so AI is making opening up a whole lot of doors that we didn't even understand before, because AI is totally agnostic. AI never gets tired. AI works all the time. So as an example, we're taking all of the clinical data from all of the UCs, because we had a data science group that extracted all the clinical data, de-identified it, and we're trying to look for signals of that might have sort of triggered a response earlier that we just don't think about. Could there be a signal or an algorithm that would prompt you to say, maybe, doctor, you should look a little harder at this patient's pancreas? So we're finding that the clinical data will, and this is already being shown in some systems, will provide some clues that we had no idea about. The other area is in radiology, because people are getting scans for a lot of different reasons. And they're learning now, and there's a really important study that came out of China, that some of these scans that are done for other reasons are showing evidence of something wrong with the pancreas. So we can probably eventually come up with a paradigm using pre-diagnostic CT scans. In other words, CT scans were done for a totally different reason for something else in a patient who later on got pancreatic cancer. This is not uncommon that we can find these pairs, and we can be able to develop some sort of strategy that just says, ew, that pancreas doesn't look quite right. Maybe that patient should be screened for pancreatic cancer, and then you fall into the other paradigm of MRCP and EUS. So I think between these clinical risk algorithms and the AI-enhanced imaging, we'll be able to really call out the high-risk group in the sporadic patients, the ones who don't have hereditary predisposition. And then we can use the blood-based assays. And of course, if we're doing that, it's high throughput, it's fewer invasive tests, it's lower cost, it's easier access, it's wider adoption. So I really believe that within the next decade, we're going to be there. I just hope that I can stay in the game long enough to see it happen. So with that, I will end, and I don't know if there's time for questions, but I'm happy to take them.
As somebody who's been in surveillance for decades, I'm so glad to ask this question to you, because you have influence, even more than the next speaker. Why are microbubbles not the standard of care in imaging of pancreas cancer?
Why are they not the standard of care? Because I don't think the studies have been done that would be able to establish it.
We paid for one, and it's like turning on a light bulb.
Thank you. Yes, sir.
So I am BRCA2 genetic, NED for 2.5 years. My son is BRCA2, mid-40s. Is there anything like your group in San Diego that can get him tested?
So he qualifies for screening based on the mutation and the family history. So that is standard of care to do the screening. He could participate in the PROCEED trial by offering his blood samples once a year.
To whom?
If he participates in PROCEED, if he signs up for PROCEED, then one of the PROCEED centers would do that.
Great. And is that covered by insurance?
PROCEED is free, but the screening that a family member would qualify for would be part of the standard of care and covered by insurance.
Okay. Thank you very much.
Sure.
Good morning, Dr. Tempero. Thank you very much for your time today. I'm a 14-year survivor of stage 4 pancreatic cancer, And, yes. And I'm happy to hear that you're involved with the NCCN guidelines. So when I was first treated in 2012 and did full-dose FOLFIRINOX, I don't think there was any screening for the DYPD gene or the UGT1A1 involved with irinotecan. And in the 13 years that I've been mentoring patients, I've come across a number of people that had severe reactions because there was no screening. So I was wondering, is there a move to make a mandatory screening for DYPD and UGT1A1 as part of the NCC guidelines?
So right now in the NCCN, the fluorinated pyrimidines, which 5-FU is one of several, those are, it's really only the colorectal cancer guidelines that have been adjusted, at least it's my understanding. But there are other diseases. Breast cancer, we use these drugs. Pancreas cancer, we use these drugs. Many other cancers. And one of the problems that comes up in pancreatic cancer is the length of time it takes to get the test back. So as you know, the mutation is extremely rare. But we can see patients deteriorate and become ineligible for therapy within 2 weeks. So we always have that sort of conundrum, like we can start the test, but if we wait and this patient is really, really sick, we might get to a road we can't turn around on. So that's one of our problems. What we need is a point of care test where really literally overnight you get the result. And there is a big movement on to try and do that so that we don't have to wait 2 to 3 weeks for this germline testing to come back.
I have seen that. I think Garden 360 is including both of those tests now as part of their testing, but you have to wait until you get tumor tissue for that.
That's right. That's right.
And the other thing I wanted to mention, so during Dr. Donahue's talk, I think it was it Jeanette Solano? Where's Jeanette? There you are. So there, to your question about G12V, there is a trial, and it's RMC 5127. It was recently announced, and the NCT number is 07349537. Sure. It's NCT, let me find it here, 07349537. And I think it was within the last month that this trial was announced. So it's an early phase 1 trial.
Thank you for finding that. I wasn't aware that they had a G12V inhibitor.
Good morning.
Yes.
Hi.
Hi.
Thank you for this wonderful presentation. So my husband was just up here talking about our son, and it struck me. I've been sleeping because my mother had pancreatic cancer, breast cancer, and uterine cancer. My grandmother had pancreatic cancer. My great-grandmother had uterine and pancreatic cancer. And so far, I've been free of it. But my son is now surrounded by the genes my husband has gratefully departed. I'm teasing, you know. And my mother's side of the family, there is no genetic connection. We've had everything tested. So what would be the best thing for our son?
So I can't speak specifically to your situation, but let me explain it this way. There are syndromes in which there's clearly a familial pattern, but we can't find the gene. And this is very common with familial pancreatic cancer. There doesn't seem to be a known gene that explains all of these families. So when we see a family with a clear hereditary pattern, that becomes the reason to do screening. Just that, not the fact that they're they don't have a mutation, that doesn't even factor in. It's the family and what's going on in the family. So we believe strongly in the biology because of what's happening in the family, and then we go ahead and screen the family.
So is this through PROCEED?
No, PROCEED doesn't provide the screening. PROCEED is basically cohort building.
Okay.
But the NCCN guidelines have a section on screening for in pancreatic cancer. And so when there is a familial pattern, then that is covered by insurance.
Okay. Thank you.
You bet.
Hi, I was just going to ask, at what age do you suggest the family start the screening? I mean, we have friends that have both parents have pancreatic cancer and things like that.
There's something called anticipation. So in hereditary families, each generation, the cancers start to occur a little bit earlier. And so what we do is take the youngest age of an affected family member and start screening 10 years before that.
Okay, I have to do my math later. Okay, thank you.
Margaret, there's
Yes.
several questions on the Zoom chat about using pancreatic juice fluid for earlier detection and work that's being done there.
So there's actually historically been a lot of effort on pancreatic juice, but you have to remember in order to get pancreatic juice, you have to first have a drug called secretin that makes the pancreas make a lot of juice so that you can collect it. You have to invasively generally go in with a scope or something like that so you can suck up the fluid and bring it out. So it's not exactly a non-invasive form of diagnosis. But there is something that we've been talking about recently, and that is the fact that, whatever is going on in the pancreas, it gets squirted out into the bowel, and then it goes all the way through. And we know we have a blood test now for colon cancer called SHIELD, which is pretty good at diagnosing, doesn't diagnose stage 1, but it diagnoses stage 2 and 3. And so we're starting to think about whether the stool can be used for some of the GI malignancies that there may be different patterns. There would be definitely a different pattern of mutation, but maybe we could do stool testing rather than pancreatic juice in the future.
Okay, great. Thank you very much, Dr. Tempero.